the attendees can have their questions ready by the end of the lecture. Dr. Sharique will begin shortly.
Assalamu alaikum. Thank you very much, Arshi, for introducing me. So have you given me access for the sharing the slides? I hope so. I can share the slides, Arshi?
Yes, you can.
Yeah.
We'll begin recording.
Yeah, so what we will do now, we'll start the webinar, and any questions I think can be at the end of the sessions. I think that will be more, or if it's something really urgent or you want to ask me, you can stop in between, doesn't matter. So I hope all of you can see the slides. So as the organizer has contacted me, Dr. Abdurrahman, and he has requested that to present some basics about the ECG. And what I know that now the participants are from all the levels, starting from I think level 3 or 4. So some of you might have not even finished the cardiovascular block. So that's why what I have selected about the today's lecture is really a basics, fundamental basics about the ECG. And I will not go to the higher level much, so that we can adopt all our participants in this discussion. Later on, if you are willing for a little higher level of discussion, we can arrange some other sessions. And also we are planning to arrange some ECG course also, which will be, we can select to a particular level so that we can discuss a little higher level of ECG in that. I hope my voice is clear, Ashi.
Yes, doctor, it is perfect.
Right. So to begin with, definitely what ECG, what we are reading, the today's sessions, our objectives are that we should learn about some simple steps to analyze the ECG. And like that, at the end of the session, you will be able to calculate the heart rate and analyze the rhythm. And by doing that, you can able to even diagnose some of the arrhythmias if you do it properly. And you can calculate the QRS axis. At least this much you can do it at the end of this session. But for before starting as such reading of the ECG directly, I would like to revise some of the basics. So when we are talking about the electrocardiogram, this is the recording of electrical activity or electrical events during one of the cardiac cycle. And it comprises of some waves, segments, and intervals, like P wave, as shown in the figure here, Q, R, and S wave, which is commonly read together as QRS complex, and the T wave and the U wave. Sometimes it appears U wave, not always. So these are the basic components. But the main thing that we have to keep in mind is it records the electrical activity or electrical events, that in a simple language I can say a depolarization and repolarization that's taking place in cardiac muscle fibers and nothing else. It doesn't give you any idea about the flow through the chamber. It doesn't give you any idea about the contraction that is taking place or mechanical activity that is taking place in the heart. It does not give any information about that. but we can get some indirect inferences and we can comment about it by analyzing the electrical activity. So whenever you record the ECG, I'll not go to the basics of leads as such because it takes too much time. The time allocated for me is 1.5 to 2 hours. We cannot cover everything. We are usually using 12 leads for recording the ECG. Or if some of the students, those who have not attended the cardiovascular block yet, for them, I should say the leads are the electrodes that we are connecting to the surface of the body for recording the electrocardiogram. So we are getting the P wave, which is atrial depolarization, QRS complex, which is ventricular depolarization, and T wave, which is ventricular repolarization. Sometimes you also get the U wave, but that is actually the delayed repolarization of papillary muscles. But normally, most of the time you will not find the U wave, and the T wave covers whole of the repolarization that is taking place in the ventricle. So these are the basic waves what we are seeing in the ECG. And before proceeding to read the ECG as such, you should know some basic concept about the ECG paper also. So ECG paper, if you have not seen here, you might have seen similar paper in schools when you are drawing some graphs in the physics and in maths. It comprises of some squares which are marked by darker lines, these darker lines. And in ECG, we are using them a terminology large square or a big square. And these big squares are divided further by some light color lines, lighter lines into a smaller square. So if you see one big square, single big square, if you just enlarge it, it contains 25 small squares, 25 small squares. And one big square is 5 millimeter by 5 millimeter in dimension. So height is 5 millimeter and breadth is also 5 millimeter in the dimension. And now we are dividing this big square into 25 small squares. But as this ECG paper just looks like a graph, and we are also using it in a graphical way. So in the graph paper, you know, there is y-axis, vertical axis, that is y-axis, and there is x-axis. So if I draw the axis on this one large square, this is y-axis and this is x-axis. Although the total number of small square is 25 inside this cube, but on y-axis it contains 5 small square, and on x-axis it contains 5 small squares. So one small square is 1 millimeter by 1 millimeter, because just now I said the big square is 5 millimeter by 5 millimeter, and one small square is 1 millimeter by 1 millimeter. But now these are the metric scales which are not useful for us, and we require time scale as well as voltage to read the ECG. And for that some conversion is required. I'll not go in much detail of it, but some basics I will tell you. The ECG paper which comes out of the machine, and the speed with which this ECG paper comes out is 25 millimeters per second. 25 millimeters per second. So just now I said that one small square is 1 millimeter. It means that 25 small squares is coming out of the ECG machine in 1 second. In other words, I can say 5 big squares from beginning from here to here. These 5 big squares are coming out of the ECG paper in 1 second. So this is how what we have done. We have converted the metric scale of millimeter into seconds. It means 1 second on ECG paper equals to 25 small square, that is 25 millimeter, or you can say 5 large square. But you know that for any measurements like heart rate or so, we usually measure for 1 minute, not for 1 second. So we can simply convert the value. We know that now 1 second is 25 millimeters. So easily you can now say that 1 minute, that is 60 seconds, equals to 25 multiplied by 60, that will be 1500 millimeter, or you can say 1500 small square. And once you know how many small squares are there, easily you can comment about the large square. 1500 small squares equals to 300 large squares. So now we know the 1 minute period on ECG paper is either 1500 small square or 300 large square. And in the same way, when we know about 1500 millimeter as well as 300 large square, simply you can comment about one small square or one big square also. So to remember, we have to fix in the mind that one large square, that is 5 millimeter on ECG paper, equals to 0.2 seconds. 0.2 seconds. From here to here, one large square is 0.2 seconds. And these conversion or the values we have got from the previous explanation, what I have given to you, that 25 millimeter equals to 1 second. So from that we got the value 5 millimeters equals to 0.2 second. And similarly, 1 millimeter on ECG paper, that is one small square, equals to 0.04 second, 0.04 seconds. So we have got on x-axis, we have converted to time scale. So now horizontally like this, if you are moving on ECG, you are actually moving the time. And vertically on y-axis, you have to remember that one large square equals to half millivolts, that is 0.5 millivolts. And 1 millivolts will be two large square, that will be 10 millimeters. That will be 10 millimeters vertically. So this one big square equals to half millivolts. So these values you have to keep in mind when we are proceeding further in further calculations. So now we have got two scales on ECG paper. First thing is duration, that is horizontally what we are getting, duration. And we know that one big square equals to 0.2 seconds. And 5 big square equals to 1 second. This is horizontal scale or calibration we got on ECG. Now, what about vertically? Vertically, 2 big square equals to 1 millivolt. That you have to keep in mind. Never forget these values. These are the basics calibration values that you have to keep in mind, or scales on ECG paper that we require in calculations. So now let's talk about some basic concept, basic components of the ECG. Then we'll move further to see how to read the ECG. I hope it's clear for even some of the juniors might be there in this group who have not attended the CVS, but I hope it's also clear for them. So now coming to the basic components of the ECG, we have 3 components in ECG: waves, segments, and intervals. Waves, segments, and intervals. Waves, these are the up and downs. The deflection up and down, what you are seeing in ECG is known as waves, just like the waves of the sea, how it goes on the up and down. These are waves. So we have P wave, we have Q, R, S complex, and the T waves. These are waves. Segments. Segments are the plateau or the straight line that is lying between the two waves. Waves are always either up or down. If it goes up, we are telling it's a positive wave. When it goes down, it's a negative wave. But in between that area, a neutral part or a straight line is known as isoelectric line. And usually the segments are isoelectric, neither they are positive, neither they are negative. And these are between the two waves. Segments are always the portion between the two waves. Intervals. These are, if you combine the waves and segments together, it becomes an interval. So a single interval may contain one wave or one segment, or it may contain multiple waves and segments together. It is known as interval. Let's see what I'm describing in actual ECG components. So we have P wave here, we have P wave. We have QRS wave, but this is combinedly known as QRS complex. And then we have T wave. These are the basic waves. And you can see here the P wave, R wave, and the T wave, they are positive waves, and the Q and S, they are negative waves. Now coming to the segments. One of the segment you can see here by the end of the P wave to the beginning of the Q, this is known as PR segment, and you can see this is a straight line. Another segment which is important for us is by the end of QRS complex to the beginning of T wave. This is known as ST segment. The significance of all this I will tell you in a short while. Now coming to interval, PR interval. Here we will count from beginning of the P to the beginning of QRS, and it contains P wave and PR segment. So as I described you before, it contains one wave and one segments together. That's why we are telling it as an interval. And it shows you whenever a word interval comes, it shows relate you to the time taken for that electrical activity to complete in the heart. Then we have a QRS interval which contains three waves: Q wave, RS, R and S wave. And one very big interval we have here is QT interval, which contains QRS complex, ST segment, and the T waves. So there are four waves and one interval is coming in this QT and a whole QT interval. Let's start with the discussion with the, now first I will describe you individual waves and segments, then we will start reading the ECG. So these individual waves, analyzing the individual waves and segments are also important when we are proceeding towards analyzing the ECG. P wave, all of us know that P wave is due to depolarization of atrium. And when I say atrium, it is both right as well as left atrium. Usually, P wave is less than 2.5 millimeter in height. And similarly, it is less than 2.5 millimeter in width. So easily you can remember 2.5 millimeter by 2.5 millimeter maximum. This is the maximum dimensions of P wave. Usually it is round in shape, upward, positive, round, upright, except it is negative in AVR. Always remember, AVR has got all negative components because this is the position of the lead which we are putting on the right arm, and the electrical activity is going in opposite direction. So all the waves are negative in AVR. And in the V1, you will sometimes find a biphasic P wave. So if you dissect out the P wave, as I said, the P wave is because of both right and the left atrium. Both of them contribute the depolarization of the right atrium as well as depolarization of left atrium. And the initial left half of the P wave is because of the right atrium, and the rightmost portion you can see here, this is because of the left atrium. And the color is also, I have given here, this is little brownish color and the bluish color what we are here. You can see here. So first component is because of the right atrium, and the second portion of the P wave is because of the left atrium. And usually it is rounded and upright. But sometimes you will find the variation in the shape. Like sometimes you will get the very tall P wave, and this is common in whenever there is a right atrial enlargement. Right atrial enlargement is there. So what will happen? The right atrium will take more time for depolarization, and it results in an increased height of the P wave, and it is also labeled as P pulmonale because many of times it is associated with the pulmonary stenosis. That's why the word P pulmonale is coming here, P pulmonale. Another variation in the shape of the P wave is broad and the notched P wave, which is also known as P mitral. And this is commonly seen in left atrial enlargement. So here what's happening, the right-sided half of the P wave is taking more time, and this results in notching of the P wave. And this is known as P mitral. As this is associated with the left side, you know, the left side, there is a mitral wall, and one of the reasons is mitral stenosis. That's why it's labeled as P mitral. So these are some of the variations in the P wave. One more important thing I just want to fix, make you to fix in your mind, make a knot in your mind, in your neurons about the P wave that we are going to utilize when we are analyzing the arrhythmias. A normal shape of P wave preceding the QRS complex suggests the impulse is originating in SA node. Remember this, a normal shape of P wave preceding the QRS complex is suggestive. I'm not telling it is that the P wave indicates you that the beats are originating in SA node. P wave is not the depolarizing wave of the SA node. But if the normal shape of the P wave is present before the QRS complex, we can take this inference that the beats are originating in SA node. Please keep it in mind. So when the P waves are absent, it's giving you a clue that beats might not be originating in SA node, somewhere else. Okay, now coming to QRS complex. It represents ventricular depolarization. Amplitude is normally 5 to 30 millimeters in height, but it varies from which lead you are talking about. Duration is usually, it's very short, just one small square to 2.5 small square, that is, you can say 0.04 to 0.1 second in dimension, usually narrow and just like a spike. Normal shape is just like a spike, a rise and the fall. Normal R wave voltage is 5 millimeters in the limb leads, so it means it's little smaller in the limb leads. And as you proceed towards the chest leads, from V1 to V6, the height of the R wave increases. Normally it is positive in all the limb leads, including AVL and AVF, except the AVR. As I mentioned before, AVR, all the components are negative. And from V4 to V6, it's positive, but usually from V1 to V3, you will find a more negative component in the QRS complex. But as you proceed toward the V6, the height of the positive component increases. That is known as progression of the R wave. As you progress toward the V6, the R wave increases in the height. So, and there is one more note I want to give it to you here that will help us in diagnosing the arrhythmias. And that is, if there is no P wave appears before QRS complex, then it means it's giving you a clue that beats might be originating in the ventricle, not confirmed. I'm not telling that it's sure. Thus, if P wave is absent before the QRS complex, this is not the sure sign that the beats are originating in the ventricle. So how to decide about it? You have to look at it, look at the shape of the QRS complex. If the shape of the QRS complex is narrow, that is what I had described to you, 0.04 to 0.1 second, it's narrow and just like a spike, then beats are originating somewhere in the atrium. If the P wave is absent, but the QRS is narrow, it means beats are originating above the ventricle, either in the junction, AV junction, or in the atrium. But if the P wave is absent and the QRS is some abnormal broad shape, then this gives us a clue that the beats are originating in ventricle and that arrhythmia is originating in the ventricle. Keep that thing in mind. That will help us in later half of today's session. Now coming to the T wave, last wave, that is the ventricular repolarization wave. Normally this is upright. This is upright, and it does not exceed 5 millimeter in the limb leads, and usually does not exceed 10 millimeters in the chest leads. And the configuration is typically round shape, not spike like QRS complex. But some variations can occur, like sometimes you will find a tented, tall, you can see here, you can compare with even the QRS complex. The R wave is smaller than the T wave, and they are not rounded shape. Their T waves are like spikes. Usually it occurs in myocardial injury or hyperkalemia. Significant, it's suggestive of hyperkalemia. And sometimes opposite to this, you will find inverted or a negative T wave. And negative T wave is suggestive of myocardial ischemia, and sometimes flat, and so it may result from hypokalemia. So either myocardial negative or inverted T wave suggestive of either myocardial ischemia or hypokalemia. You have to confirm it by doing the lab investigations. Coming to segments. Segments, as I told you, there are two segments which we are going to check here is PR segment and ST segment, and they are always isoelectric. Coming to PR segment, this is from end of the P wave to the beginning of QRS complex. And this PR segment is giving you a time delay that is occurring at the AV node for the passage of impulse. We know that when the SA node fires an impulse, it depolarizes the atria first, then it goes through the AV node and bundle of his to the bundle branches. And when it's crossing through these AV junctions, through the AV node and bundle of his, there is a delay of impulse that is, this is shown by that area PR segment over here. ST segment. ST segment is another isoelectric zone here, which is at the end of the QRS complex to the beginning of the T wave. This portion from here completely, this is ST segment. It begins from the J point. This is known as J point, where the S wave ends and the isoelectric zone start. That is known as, that junction is known as J point. ST segment is quite important segment for us. At its elevation of ST segment more than 1 millimeter from the baseline is suggestive of myocardial infarction. So if ST segment is elevated, it gives you a clue about myocardial infarction. But if ST segment is depressed, 0.5 millimeter below the baseline, it is suggestive of ischemia or digoxin toxicity. So here, as I have shown here, this is isoelectric ST segment, and you can see here the ST segment elevation is there. The ST segment, this is the baseline shown by the dotted line, and ST segment is elevated. And in another picture here, I have shown here the ST segment depression, which is a sign of myocardial ischemia. All ST segment elevations are not myocardial infarction. Remember this. And there is a criteria for myocardial infarction. First thing, the elevation of ST segment that is occurring should have a convexity upward, a convexity upwards. In this green picture, you can see the convexity is downwards, although there is ST segment elevation, but convexity is downwards. So this is not myocardial infarction. So simple way of doing that is draw a circle around the ST segment. And if you see a crying face made by the ST segment, it is diagnostic of myocardial infarction. But if there is a smiley appearing over there, your heart is telling you, doc, take it easy, I'm fine. So there is no myocardial infarction over here. Another criteria for diagnosing the myocardial infarction is that the ST segment elevation should be more than 1 millimeter. It means it should be more than 1 small square. One more criteria is that these changes of ST segment elevation should be in more than 1 consecutive leads. Consecutive means the leads related to that area. If I'm talking about inferior wall, you know that the lead 2, lead 3, and lead AVF, they are related to inferior wall. So if ST segment elevation is coming only in lead 2, you will neglect it. It's not myocardial infarction. But if the similar changes are also reflected in lead 2, 3, and AVF, all 3 of them, then it is diagnostic of myocardial infarction. So these 3 criteria, how much it is elevated, how it is elevated, where is the convexity, and in how many leads. This is important for diagnosing the myocardial infarction. Coming to intervals, we have PR interval, that is from beginning of the P wave to the beginning of QRS complex, and it contains P wave plus PR segment. It means that the PR interval is showing you the depolarization, the time for depolarization of the atria, as well as the delay that is taking place at the AV junction. Similarly, the QRS interval is showing you the whole time taken for ventricular depolarization. depolarization. Similarly, we have a longest interval here, QT interval, which shows you a whole time for ventricular depolarization as well as repolarization, a recovery. Whole phase, whole ventricular activity is shown by the QT interval here. So PR interval is showing you atrial depolarization plus delay at the AV node, and in other words, you can say time taken for the impulse to travel from SA node to the ventricle through the atrium and AV junction. Normal duration of PR interval is 0.1 to 2.2 seconds. That is, you can say 3 to 5 small squares. 3 to 5 small squares. This is the normal duration. If the PR interval is prolonged, it's coming more than 5 squares, suggesting that there is some problem at the junction, and it is suggestive of atrioventricular block. Atrioventricular block. Or if the PR interval is narrow, opposite to that, you can say that impulse is not traveling to ventricle through the AV junction, but it has taken some other route, some faster route to travel to the ventricle. So in that situation, the PR interval will be very narrow or even disappeared. QT interval, this is the longest interval we have on ECG, and this contains whole of the ventricular depolarization and repolarization together. Normal value is between 0.36 to 0.44 seconds, but it varies according to the heart rate. If the heart rate varies, the QT interval will also vary. So correct value is known as corrected QT interval. That is coming from this formula when we are considering the heart rate. And the normal value for that in male, it is 0.45, less than 0.45 seconds, and in female, it is 0.46 seconds. Prolonged QT interval shows that patient is at risk of developing a life-threatening arrhythmias. So it's alerting you that these patients might go into the arrhythmias. I have shown you so many values. So before proceeding towards how to read the ECG, just to sum up all those things and to remember, I'm giving you one clue here, easy way to remembering this. You can remember the formula of 2.5 small squares. So if you see the P wave, they are, I told you, they are not, they are always less than, not more than 2.5 small boxes. PR segment, it is also maximum limit is 2.5 small square. PR interval, just double it. Again, you see 2.5, you are doubling it, 5. It's coming of 5 small square. So always you have to remember in a multiple of 2.5. P wave 2.5, PR segment 2.5. If you combine both of them, it is the PR interval, that is 5 small squares. QRS complex, again, the maximum range is 2.5 small square. It will not cost more than that, not more than 0.1 second, 2.5 small squares. QT interval maximum is 10. Again, you see multiple of 2.5. So QT interval, usually it's not more than 10, or you can say simple way of remembering this is it's double of PR interval. Maximum range of QT interval is double of PR interval, that is 10 small squares. So this is just easy way of remembering all these things. By keep this thing in mind, and we will proceed further of reading the ECG. Excuse me. So we have to, now I have too much taken your mind into the confusions, and still some of the kids might be thinking what this man is talking about. We have came here to read ECG, and he's just giving us values and the range and the calculations. So let's proceed. Let's be cardiologists, read the ECG directly. So ECG, for the beginners, always I'm suggesting don't skip the steps. ECG reading is one of the interesting and easiest thing in the cardiology if you do it in a correct way. But the problem is that whenever we just go further, we skip the steps, and that makes us the problem. So always remember there is 3 simple steps of reading the ECG. First one is rhythm analysis, determining the mean electrical axis, and analyzing the individual waves and segments. So if you follow these 3 steps, the analysis of the ECG becomes quite easy for us. Individual waves and segments, some of it we have analyzed just now while I was describing to you these waves. And more, I will do it here with the rhythm analysis. So we don't have to go separately for this 3rd step. While doing other steps, automatically we are analyzing the individual waves and segments together. So 1 step you see already we have omitted, and now remains 2. Rhythm analysis and determining the mean electrical axis. Out of that, first we will go for rhythm analysis. Before going for rhythm, we should know what is, because we have so many beginners might be with us who has not done the cardiovascular block. So what is the normal rhythm of the heart? Normal rhythm of the heart is known as normal sinus rhythm. What does it mean by normal sinus rhythm? An easy way of remembering it is a star criteria. To label the rhythm of the ECG as normal sinus rhythm, and we are telling it is a star criteria. Star because star has got some points over here. Some star has got 4, some has got 5. My star has got 5 corners or spikes, and each corner has got 1 value to remember, 1 condition for sinus rhythm. First condition to label the rhythm as sinus rhythm is beats should originate in pacemaker, that is SA node. So beat should originate in SA node. Second condition is the beats that is originating in SA node should follow the normal rate, because our heart rate is coming from SA node. Whatever the firing rate of the SA node, that is our heart rate. And the normal value for this, you know, the range is 60 to 100 beats per minute. So it's originating in SA node with the normal rate of 60 to 100 beats per minute. Third condition is after originating in SA node with the normal rate, it should follow the normal path. What is the normal path? From SA node, it should depolarize the atria first through the internodal fibers, then reach the AV node. And by crossing the AV node, it reaches the bundle branches in the interventricular septum, and then crosses through the Purkinje fibers and spreading through the rest of the ventricle. This is the normal path. So normal path with normal speed. So while crossing through this normal path, which I described to you from SA node to AV node to bundle of His to the Purkinje fibers, not only through this normal path, but it should also follow the normal speed through this path. And we know that the speed of conduction is highest in the Purkinje fibers and slowest in the AV node, that is AV junction. That's why there is a delay of impulse at AV node. So we should remember this. So now we got 4 criteria: beats originating in SA node with the normal rate, should follow the normal impulse, and should follow the normal path, or should follow the normal path with that of normal speed. And the 5th one is most important one, that is the tail of the star. So this tail is invented by me, so I take the credit of this tail. Other all 4 criteria is invented by someone, so that is not important for me. So rhythm analysis, let's come to the, starts analyzing the rhythm. And for analyzing this rhythm, what we are doing now, just now we have seen this star criteria. While looking at the ECG, we are confirming that your heart meets these 4 criteria to be labeled as normal sinus rhythm. And how to do that? For doing this, we are following the 5 steps. Determining the regularity, calculate the rate, assess the P wave, determine the PR interval, and determining the QRS duration. So these are the 5 steps we had to follow. Don't get afraid of the so many number of steps. This becomes easy when we will be reading the analysis together. So first thing is regularity, rate, P wave, PR interval, and QRS duration. Let's do it one by one together. First thing is regularity. When we say regular, what does it mean in terms of ECG or in terms of heart? We are checking that all the beats, they are coming at the same interval. Or in other words, I can say all the cardiac cycles that is happening, it's having the same time duration. In other words, you are measuring the time duration from one beat to another beat. And how to do it? Always for determining the rhythm, you are using the long lead 2 in the ECG, long lead 2, that is known as rhythm strip, or another word is known as reference lead. This is also known as a reference lead. So whenever you check the long lead 2 means it should contains many QRS complexes. That's why we're telling long, not just one or two. You should be able to see multiple QRS complexes to analyze the rhythm. And what we are seeing here in determining the regularity, we are checking the distance between the R to R, one R wave to another R. Here the R wave is showing you a QRS, the ventricular depolarization. So from one ventricular depolarization to the next one here, you are measuring the distance. Why we are selecting R? Why not going for P? Why not going for T? You may ask this thing, but it's just ease that R wave is more prominent wave in the ECG. That's why we are picking it and easy to measure it. How to measure the distance? Either you can use the caliper for measuring the distance, or you can count the squares between the two R waves. But both these methods, by caliper as well as by counting the small square, it takes long time. So easiest way of doing that is take a piece of paper and put the marking from one R wave and the second R wave here. And then simply just go on moving the paper along the ECG, just to check that our intervals are same throughout this rhythm strip or not. Once you have done that, you can say that this is regular, because now here what we have done, all RR intervals are at same. So our interpretation will be it's regular. And this step is very much important. If the ECG you found that the RR intervals are same and you are labeling it as a regular, the next step, that is the calculation of the heart rate, becomes easy for us and we can develop a formula for it. But if it's not regular, the beats are not coming at the regular interval, you have to measure the heart rate by different formula. But now here in our case, it was regular. But the question comes, what if it is irregular? Just now we have seen the example, it was regular. All RR intervals, they were coming at the same distance, same intervals. It means all the beats, they are coming at the same interval. But what if it is irregular? It means all the beats, they are not coming at regular interval. Then again, you have to do the two classifications of it if it's irregular. Either it can be regularly irregular. Regularly irregular means there is some regularity in your irregularity. Here you can see the RR interval is short here and then again long. Then again you will find RR interval of 3 biggest square. Then again it's long. Then again it's 3 biggest square and again long. So you can see a pattern is there of irregularity. You can predict that one beat will be shorter, another one will be longer. Or it can be irregularly irregular. In irregularly irregular means there is no regularity in the irregularity. You cannot predict what happens next. You can see here, sometimes it's just 1.5 small square, sometimes it's 2 big squares, sometimes it's 2.5 big squares. So you cannot say what's happening to the next beats. You cannot predict about it. And these things, these variations in the irregularity, whether it's regular, whether it's regularly irregular, or whether it's irregularly irregular, this helps you to classify the arrhythmias and to help you to reach the diagnosis of arrhythmias or the origin of the arrhythmias, where they are. So now we have seen that in our ECG paper, what I have shown in the sample, it was regular. So we can go for next step, that is calculating the heart rate. And it becomes easy for us, as in the previous step it was regular. So what you have to do here, just mark one R wave on ECG paper which falls on the darker line. But this is not compulsory. This step which I am telling to you, the mark one R wave which falls on the darker line, it's not compulsory. But if you get one R wave on the darker line, it becomes easy for you to calculate or for counting the squares. So first mark the R wave which falls on the darker line and count the distance to the next R wave. And now we know that the distance to the next R wave, how much we can count? 1, 2, 3, 4, 5. 5 big squares. Or you can even convert it into a small square, that is 5 big squares. Each big square contains 5 small squares. So 5 big squares will contain 25 small squares. So either you can measure it as a 5 big square or you can measure it as a 25 small square, one and the same thing. And now from the previous step, we know that it's regular, so we can use the formula now. What is the formula? If you are counting the small square, then the heart rate equals to 1500 divided by number of the small squares between the R and R. Or if you are counting the big squares, then the formula will be 300 divided by number of big square between the R and R. Let's do it practically. First, we will use the large squares. Mark the R wave which falls on the darker line. Count the distance to the next R wave. Now the distance to the next R wave is how many big squares? 1, 2, 3, 4, 5. So our formula is 300 divided by number of big squares. Number of big squares we have are 5, and the answer will be 60 beats per minute. Now we can do the same thing by using the small squares. We know that same thing by marking the R wave which falls on darker line, count the number of the small squares to the next R wave. And this is 5 big squares, so I can convert them into smaller squares, that is 25 smaller square. And now this time's formula will be different, that is 1500 divided by number of small squares. 1500 divided by 25, and answer will be 60 beats per minute. So this is very simple. But the question comes, what you will select, when you will select the big square and when you will go for counting the small squares. You see, first, what was the first step? First step was to pick the R wave which falls on the darker line and count the distance to the next R wave. If the next R wave is falling on the darker line, luckily, then you count the larger squares. But if the second R wave is falling somewhere in between here, not on the darker line, then better to select the small squares. This is the criteria for counting the larger square or smaller square. But again, it takes too much of time. And your condition is like this, that I am in the medicine because I hate mathematics, isn't it? I'm telling about me, I'm not telling about you. I know that all of you are professional and you like mathematics too much. And you never use the mobile phone for calculations. You all are doing the manual calculations. I know this, isn't it? Okay. And so I'm showing you my condition. I have selected medicine because I don't like maths. So what to do? Let's search for some escape door. So when you're practicing on the bedside, it takes too much time for calculation. What we will do now here, one crude method I'll show you. Pick one R wave which falls on the darker line and check the distance to the next R wave. If the next R wave is after one big square, then by using the formula of big square, you know that heart rate is 300 divided by 1, that is 300. If the second R wave is after two big square, then you know that the heart rate is 150 beats per minute. If the second R wave by chance is after 3 big square, then the heart rate is 100. If the second R wave is after 4, heart rate is 75. If the second R wave is after 5 boxes, then the heart rate is 60. And similarly, if you're after 6, the heart rate is 50. So normally in the living human being, the heart rate will not vary from 50 to 300. And these values are not difficult to remember. 300, 150, 100, 75, 60, and 50 is quite easy to remember. And when you are seeing multiple ECGs, hundreds of ECG in a daily routine, it becomes stick to your mind. This picture easily, you can take the snapshot of this picture, where not in your mobile, in your mind. This will be, snapshot will be there, and that you can use. But somebody may ask me that if the second R wave is somewhere in between, not exactly falling on the darker line, say for example here, so what will be the heart rate? You can predict by the crude method. You see that if my pointer is here somewhere between 100 and 150, so you can roughly say the heart rate might be 125 beats per minute. Or if I'm coming to 100, you can say it might be approximately 110 beats per minute. Or if I am reaching near to 150, you can say it's 140 beats per minute. Because at the end of the day, finally we have to know we don't want to know the exact heart rate 143.5 or 142 beats per minute. No. For treating the patients, only rough idea we want from the ECG, how much is the heart rate? It's going above 100, or it's going above 150, or it's going above 200 for diagnosing some of the arrhythmias. We just want approximate value. So this is a crude method which will save our time, and it will not make you frustrated because we are doctors. So I want to see you happy always. Go on smiling, even if you are wearing the mask. We can see from your eyes that you are smiling. So calculating the, now we have what we have seen. I have shown you the formula for calculating the heart rate when it's regular. And some of you might be thinking now, I can read your minds that how to calculate the heart rate if rhythm is irregular. If it's irregular rhythm, we cannot use the formula because that formula can be used when the rhythm is regular. What to do then? You have to select the 6-second strip on the ECG paper. This is the 6-second strip I have shown. How I have selected the 6-second strip, because we know that 1 second on the ECG paper equals to 25 small square, or you can say 5 big square. So what you have to do? You have to count 30 big square for counting the 6 seconds, because I told you 5 big square equals to 1 second. 30 big square equals to, this is a center mark I have marked here for 15 square. This is 3 second and the 3 second. Most of the now recent ECG machines, when they give the printout, there is a marking here like this for 3 seconds. So no need of counting, no need of wasting the time. Simply just you can select the 2 marks and it will become 6 seconds for you. So select the 6-second strip on the ECG paper and count the number of the R wave during this 6 seconds. So in this example, the number of R wave here are 10. What you have to do during this 6 seconds, your heart is beating for 10 times. So just multiply it by 10. Why we are multiplying it by 10? Because you have measured it in the 6 seconds, but usually heart rate you are measuring for 60 seconds. So you have to multiply it by 10 and you will get the heart rate. So the heart rate in this patient will be 100 beats per minute. I hope it's clear. Now coming to the third step, what we are doing, we are analyzing the rhythm. And in the rhythm analysis, we have done 2 steps, regularity, and the second thing is measurement of the heart rate. Coming to the third step, which is assessing the P waves. Assessing the P waves. And as I told you before, P waves are nothing but atrial depolarization wave. When assessing the P wave, there are some questions you need to give attention to, or you need to search the answers for these questions. What are these? Are there P waves? You have to look at the ECG or the rhythm strip. Are there P waves? Yes, 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 yes. We have P wave over here. And the second question is, do the all P wave looks alike? All the P wave, they are normal in the shape and they are similar in the shape. They looks alike. First of all, why you ask the first question, are there the P waves? You remember the strike criteria? We are analyzing the rhythm, the normal sinus rhythm. And for the first criteria for the normal sinus rhythm is that the beat should originate in SA node. And I told you that whenever the P waves are present, these are the suggestive that the beats are originating in SA node. When the P wave is present and they are normal shape, upright and the round shape, it suggests that the beats are originating in SA node. That's why you are asking whether the P waves are there or not. They do the all P wave looks alike. This gives you idea that all the beats, they are originating in the SA node. It's not happening that some of the beats might originating in somewhere else in the atria. Then that particular P wave might not be of a normal shape. I will give you an example of it after some time, how it differs. Third thing is, do the P wave occur at regular rate? How you have calculated the RR interval, now you have to calculate the P to P interval to check that your SA node fires an impulse at a regular rate, and some impulses are not missing, some beats are not missing. One very important question related to arrhythmias, is there one P wave before QRS complex? You have to make sure that before every QRS complex there is a P wave. So we can see here before the QRS there is P, yes. There is P here before QRS. There is P here before QRS, and same here, 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 and here. So what inference you are getting here? As I told you before, if there is a P normal shape of the P wave before a normal shape of a QRS complex, it suggests you that the beats are originating in SA node or somewhere in atria. But if the P wave is absent, then it shows you that the beats are not originating in SA node, it's somewhere else. So it's giving us idea that it's not only originating in SA node, but also following the normal path. So this is very important step you are doing in terms of arrhythmias. So interpretation, we can do that normal P waves with one P wave before each QRS complex. And now coming to determining the PR interval, the fourth step, we are at the fourth step of the rhythm. PR interval, just to revise, it's from the beginning of the P wave to the beginning of QRS complex, and you have to count the number of the small squares now here, and then convert it into the seconds. So the value what we are getting here is normal value, you know, it's between the 0.1 to 2.2 second, that is 3 to 5 small squares. And the clue I have given you, it not crossing more than 2.5 millimeters. Sorry, not crossing more 5 millimeters, that is 0.2 seconds. And value what we are getting here is 3 small squares, so it is 0.12 seconds. How to convert it? You know that each small square is 0.04 second. So we are getting 3 small square here multiplied by 0.04. So it is 0.12 seconds. QRS duration from the beginning of from the Q to S completely, QRS duration. And you know that normally it's very narrow, 1 to 2.5 small squares. Value with us here, if you count, is 2 small square. So 0.08 second, because 1 small square is 0.04 second. So it is normal duration for us. What we got now, we have completed the 5 steps. All the 5 steps we have completed. Let's summarize it together, make a checklist. What was the first one? Regularity. It was regular for us. Rate, 60 beats per minute, because we have 5 big squares. P waves were normal with 1 P wave before each QRS complex. PR interval is 0.12 seconds. QRS duration is 0.08 seconds. So all these values are within the normal range. What is your interpretation? Interpretation will be normal sinus rhythm. It's not normal rhythm, it's a normal sinus rhythm. This word is important here. So what we got now, we got the checklist. Very important checklist if you want to diagnose an arrhythmia. So if everything is there, fine, within the range, this confirms that this is a normal sinus rhythm. If a single value is missing, is all what we are doing by doing these 5 steps. We have confirmed that the beats originates in the SA node. Its rate is normal. Impulse follows the normal path, and impulse follow the normal path with normal speed. By PR interval, you are measuring the speed through the atria plus AV node. By QRS duration, you are measuring the speed through the ventricular path. So we have completed this criteria, and we have read this criteria, and we have confirmed that the rhythm is normal sinus rhythm. But what if some of the things are missing? Like say it's regular, it's not regular, but all other things are normal. Or you can say everything is normal, but the rate is not in the range of 60 to 100. Either it's less than 60 or more than 100. Or the P waves are not present, or something abnormal shape of P wave, or PR interval is prolonged, or QRS duration is prolonged. QRS complex is abnormal shape. What then? Is it a normal sinus rhythm? What you label it as? We will label it as arrhythmias. Anything, if a single of these 5-point checklist is missing, just go for diagnosis of arrhythmias. And please keep one thing in mind, that all the arrhythmias are not pathological. It's not abnormal. All the arrhythmias are not abnormal, because simply a heart rate increase of more than 100 beats per minute is tachycardia, is also a type of arrhythmia. But it can be quite physiological. After hearing a physiology lecture, your heart rate can either go up above 100, or some of you might be feeling a heart rate below 60 now. Isn't it? So it's not abnormal. This is quite normal after physiology lecture. So what we have done, we have got the 5-point checklist. Anytime you will see the ECG, this is a 12-lead ECG. You will have lead 1, lead 2, lead 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6, and this is a long lead 2. Just pick up this long lead 2 and go through these 5 steps. Confirm these 5 steps. If all the 5 steps is okay, you have done it. This is the normal sinus rhythm. If anything is missing out of it, simply this is arrhythmias. This is arrhythmia. Now, what if I cannot go in much details of arrhythmias and more of the abnormalities because of the time strain. We cannot cover whole of the ECG, but some, as arrhythmia is one of the important topic of the electrocardiogram while reading the ECG. And really, believe me, the topic of arrhythmia in ECG itself creates arrhythmias in so many students, tachycardias, isn't it? And so many ectopic beats originates in us when we are reading the arrhythmias, because we think it's too difficult. No, it's very simple. So I'll just give you some of the points, some of the clues which will help you in classifying and diagnosing the arrhythmias. Definitely, I cannot cover all here. So the normal sinus rhythm, we know that beats originate in SA node, conducted via the normal pathway with a normal speed. This is a normal sinus rhythm. If anything deviates from this, this is arrhythmias. So this is a 5-point checklist. If it deviating from it, it is simply an arrhythmia. Now, arrhythmia formation can be at different place. The defect can be in SA node. The defect can be in the atrial cells. The defects can be at AV junction, at AV node and bundle of His, or it can be ventricular cells. So on the basis of that, we can classify the arrhythmia, and this map should be in your mind when thinking of the arrhythmias. So arrhythmia can be because of the defect of formation of the impulse, or arrhythmia can be because of defect of conduction of the impulse. These two are possibilities there. So defect of formation of the impulse, normally we know that the impulse originate in SA node. So if the arrhythmia are originating in SA node, they are known as sinus arrhythmias, sinus arrhythmia. But if it not originate in SA node, these are non-sinus arrhythmias. If you are classifying the arrhythmia into non-sinus, then the question comes, if it's not originating in SA node, where does it originates? There is possibility, three possibilities are there. Either it's originating in atrium, somewhere in the atrium, but not in SA node, or it originates at AV junction, AV node and bundle of His, or it originates in the ventricle. So on the basis of that, you can classify the arrhythmia into atrial, junctional, or ventricular arrhythmias or tachycardias. And the defect in the formation can be in terms of rate, not origin. It's originating properly, but it's too fast or too slow, tachycardias or bradycardias. So it might originate in SA node, but faster or slower, or it might originate somewhere else and can be faster or slower. So based on that, we can go for diagnosis. And as I told you before, it can be defect of regularity. You have to look into it, whether it's regular or irregular, or the onset of arrhythmia, how it is there, whether it's just a passive arrhythmia where the SA node is not working and some other beat has taken place, or it's an active foci which is firing an abnormal impulses. Or it can be a conduction defect, beats originating in SA node, but there is a defect in conduction between the SA node and the atria, then this is known as sinoatrial block. Or sometimes there is a defect of the conduction between atrium to the ventricle, which is known as AV block. And all of you know that they can be classified into the 3 degrees, first and second and the third one. And second one is again subclassified as Mobitz type 1 and type 2. I'll not go into detail of it now. Or it can be a defect in ventricular conduction system, like in the bundle branches. There can be right bundle branch block or left bundle branch block. So whenever arrhythmias come, this whole thing should be in your mind to find out which type of arrhythmias is there. And I'll give you some clue about it, how to diagnose it from the ECG in a few points. So we have 5 basic types of arrhythmias: arrhythmias of sinus origin or of ectopic origin. It can be, as I said, in the atrium, junction, or ventricle. It can be because of reentrant arrhythmia. This is the etiological classification. What is the mechanism behind the arrhythmia? It can be conduction block, or it can be abnormal pathway that is known as pre-excitation syndrome. So on the basis of if you combine whole of the thing, basis of the origin, basis of the etiology, and how the arrhythmias, it can be classified in a different way. Let's take an example of some of it, but whenever you want to diagnose the arrhythmias, always ask these 5 questions to yourself. Is the rhythm regular or irregular? Look for it. What is heart rate? Are the P waves present? What is the relationship between the P wave and the QRS complex? What is the PR interval? This is prolonged or shorter. And are the QRS complex narrow or the wide? Because I told you, when the QRS complexes are narrow, they are suggesting that the beats are originating in the atrium. But if the QRS complexes are wide, it suggests that beats originate in the ventricle. So by keeping this thing in mind, let's proceed further. I'll give you some of the examples of arrhythmias or the rhythm disturbances. Then we'll proceed further. Definitely, as I told you, because of the shortage of time, I cannot cover everything. Just few examples, and then you can utilize the knowledge. And in future, inshallah, we'll arrange some lectures for the higher levels. Arrhythmias first thing I selected was arrhythmias of the sinus origin. So if you follow the same 5 steps, what we have done before, the first step is regularity, rate or regularity. Here the step has moved different. First thing is regularity. So it was regular here. The rate, you can see, if you measure the rate here, this is the R wave falling on the darker line, 1, 2, 3, 4, 5, 6, 7, 8. So distance to the next R wave is more than 8 big squares. So approximately, if you use the formula, exactly if you use the formula using the small squares, because the second R wave is not falling on the darker line, the heart rate which is measured here is 35 beats per minute. We know that the normal range is 60 to 100 beats per minute. Regularity, it's regular. P waves, yes, P waves are present. All looks alike. They looks normal in shape. And there is one P wave before each QRS complex. Here also before QRS complex. Here also before QRS complex. Although this is a small strip of ECG I have shown to you because of enlargement, ideally it should be a very long strip for commenting on the rhythm. So P waves are normal. Coming to PR interval, if you count the PR interval from beginning of the P to the beginning of the QRS, it's 0.12 seconds. That is 3 smaller squares, which is normal. We know that the range is 3 to 5 small squares, 0.12 to 0.2 seconds. QRS duration, 0.10 seconds. We know that normal range is from 0.04 to 0.1 second. This is also within normal range. So now in this, we got the checklist. It's regular, it's P wave are normal, PR interval is normal, QRS duration is normal. But the first criteria here, rate, we know that the heart rate is not within the normal range. So I cannot label this as a normal sinus rhythm. This is arrhythmia. Our diagnosis should be arrhythmia, confirmed, this is arrhythmia. Now, after confirming the arrhythmia, now you have to ask all those questions to classify the arrhythmias, what type of arrhythmia it is. Is it a sinus arrhythmia or a non-sinus arrhythmia? How to confirm it? This question can be confirmed from the P waves. Are there P waves present? If normal shape of P waves are present, as I told you, it suggests that the arrhythmias are of sinus origin. It suggests you of. Okay. So now we have confirmed we have a normal P wave here. So our arrhythmia is a sinus arrhythmia. Now what is the defect? Defect is in the rate. It is slow or fast? It's slow. So we had to label it as a bradycardia. Now combine both sinus arrhythmia and the bradycardia and you will reach the diagnosis, that is sinus bradycardia. And sinus bradycardia can be non-pathological conditions, not always required to be pathological. So as I said before, all arrhythmias are not pathological or abnormal. Second example, exactly opposite to the previous one, but the same step you have to follow. Rate. Here the rate is too high, above 100, too high, it's too high. Regularity, P wave, PR interval, and QRS duration. You see the PR interval is 0.16, QRS duration is 0.08, P waves are normal, everything is normal, but the rate is 130 beats per minute. So it is arrhythmia, definitely, no doubt, it is arrhythmia. What type of arrhythmia? Sinus or non-sinus? Pick up the P wave. If P waves are present, this gives you a clue that this is sinus arrhythmia. So our diagnosis is sinus arrhythmia again. Now what type, what is the defect? Defect is in the rate. And here rate is too fast, which is known as tachycardia. So now combine the defect with the diagnosis and it will become sinus tachycardia. Diagnosis is sinus tachycardia. You see how easy it is to diagnose the arrhythmias. We are afraid of it, but the diagnosis of arrhythmia is the most easy thing if you follow the steps. Okay, now one more example. Let's see the regularity. First step is the regularity. And you can see here, it's irregular. Clearly you can say that it's irregular. But there is a pattern here. If you see the first portion of the ECG, the RR interval is very broad, but if you come here in the central portion, the RR interval is very short. But again, if you see the second portion, RR interval is broad. And if you see this long strip of ECG, which was not possible for me to show it on the screen, the same pattern is repeated. There is a broadening of RR interval and there is a shortening of RR interval. There is a broadening, there is shortening. So again, what's happening here? The heart rate, if you say it's normal, the P wave are normal, the QRS duration is normal, PR interval is normal, everything is perfect. Only defect is you are not getting it regular. Is it so? Can I label it as a normal sinus rhythm? No, it's irregular, so I cannot label it as a normal sinus rhythm. This is arrhythmia. What type of arrhythmia? It is sinus arrhythmia because P waves are present. What is the defect? Defect is only irregularity, and this irregularity is following some pattern. And this type of arrhythmia is known as sinus arrhythmia simply. And this is nothing but a normal change that we can see with the respiration. Normally with the inspiration, the heart rate decreases, and when you expire, the heart rate increases, which is not in a quiet breathing, which is not evident much, but when the patient breathes heavily, deep breaths, then it can be visible. This change can be visible, but there is no defect in the heart. So this is another example of sinus arrhythmia. So I have given you 3 examples of sinus arrhythmia where it can be non-pathological. Let's take some example of non-sinus arrhythmia. We have seen too much of non-sinus arrhythmia. Let's take 1-2 example, then we'll move further. I cannot discuss much of the arrhythmias. Atrial, or an example of atrial junctional beats. Let's look at the ECG. And same 5 steps. Whenever you see an ECG, go for same 5 steps. Regularity, occasionally irregular. You can see here, this RR interval and then this one. It's not same, but rest are same. Again, there is a defect comes here. So occasionally there is irregularity is coming. Heart rate, normal. P waves. The second and the 7th P wave is different in shape or contour. You see the first P wave, look at the second P wave, how it looks like. Different in shape, it's a biphasic, some positive component and the negative component, both are coming in this. This is normal, this is normal, this is normal, this is normal. Again, the 7th one, same. It's a different in shape. What else? We have PR interval normal, except similar, same second and the 7 because they are abnormal in shape. QRS duration, they are normal. So can I label it as a normal sinus rhythm? No, definitely, because P waves are not normal and there is occasional irregularity is there. So this is arrhythmia, definitely. This is arrhythmia. But can it be a sinus arrhythmia or non-sinus? This is sinus arrhythmia because P waves are present, but there are some occasional abnormalities or ectopics are coming. What do you mean by ectopic? When the P waves are normal shape, it shows you that the beats are originating in SA node. But when I told you P waves are not normal in shape, it shows you that beats are originating somewhere else. But P waves are present and abnormal shape. It means that they are originating in atria only, because you can see the shape of the QRS. They are narrow. QRS is, after this abnormal shape of P wave, the QRS is narrow. It means that the beats are not originating in the ventricle. They are originating in atria only. And there is, throughout the ECG, only occasionally you are finding this defect, not regularly. So this is nothing but premature atrial contraction or premature atrial premature beats, which can be, again, this can be quite always doesn't require to be pathological. This can be seen in non-pathological conditions also, like you are stressed up, you are smoking too much, you are taking too much of coffee just before the exams also can be. But some of the premature atrial premature beats can be pathological and can later on be converted to serious arrhythmias. So whenever you see APCs, it should be investigated. It may not be of the things to worry, but it needs to be investigated. What is the reason for it? So premature atrial contractions can lead to some very serious arrhythmias. Okay, two more examples of arrhythmias, just quickly. You can see here the pattern is regular, isn't it? Rate is too high. P waves are absent. You can't see the P waves here continuously. P waves are absent. So if P waves are absent, it means that beats are not originating in SA node. Then the question comes, if it's not originating in SA node, does it originate in atria or ventricle? What you will do, just look at the QRS complex. QRS complex are narrow. It means that the beats are originating in atrium, not ventricle, above ventricle, sorry. So these beats are originating in atrium and the rate is too high. So it's arrhythmia definitely, and the tachycardia is there. Rate is going approximately 150 beats per minute. Yeah, it's too big square. You can see here, too big square. 300 divided by 2 is 150 beats per minute. P waves are absent. Rate is too high. What is this condition? This is definitely a supraventricular tachycardia. One of the type of this arrhythmia, you will label it as supraventricular tachycardia. And the final diagnosis is paroxysmal, the supraventricular tachycardia, PSVT, paroxysmal supraventricular tachycardia. And just as I told you before, even the premature atrial contractions sometimes can be preceding the paroxysmal supraventricular tachycardia. Normally here the heart rate is between the 150 beats per minute to 250 beats per minute. And here you can see initially the ECG was normal and suddenly paroxysmally the tachycardia started. And the P wave, initially the P wave was appearing here, then the P wave disappeared. So the beats are originating somewhere else in the atrium is possible here. P waves are lost. Most common etiology for this paroxysmal supraventricular tachycardia is re-entrant circuit loop in the AV node. You are developing a re-entrant circuit around the AV node. This is a re-entrant circuit mechanism is shown here, where the impulse is revolving around some defective focus. So here the problem is at AV node and the impulse is revolving around there. One of the commonest cause of the PSVT. Another example. Again, the same 5 steps you have to follow. Regularity, it's regular. Rate, if you see 70 beats per minute. Are there P waves? Some may say that these are P waves. No, these are not normal shaped P waves. You can count the width, 1, 2, 3, 4. These are 5 big square and more than 2 small squares in the height. So normal dimension of P wave is not like this. And P waves don't have spikes like this. P waves are, we know that they are positive and they are curve. A smooth curve is there for P waves. So these are not P waves. They are some other waves. Atrial depolarization waves are there, but not P waves. So you can say the beats are originating somewhere else in atria. And if you look at these waves are looking like the saw tooth, the saw which we are using to cut the wood. And these are known as flutter waves. And this example is another example of supraventricular tachycardia I have given, because if you count this number of the P waves, here the atrial rate, the number of the P waves coming per minute will go above 250 beats per minute. Ventricular rate is normal because all the P waves, they are not conducted to the ventricle. Because here I told you the atrial rate, depolarization rate is very high, about 250 beats per minute. But the AV node cannot conduct all these impulses to the ventricle. because once it's depolarized, there is a refractory period is going on, and it has to complete this one conduction, then it will take another waves. That's why the ventricular rate, if you count, it seems to be normal, but atrial rate will go about 250 beats per minute. This is another example of supraventricular tachycardia or arrhythmia, a non-sinus type of arrhythmia, supraventricular arrhythmia, atrial flutter. And again, the etiology here is reentrant pathway somewhere in the atrium. When I say the PSVT, paroxysmal supraventricular tachycardia, there also the etiology was reentrant pathway, but it was around the AV node. But here the etiology is reentrant pathway is developing in the atrium. And you can see the heart rate is usually above 250, the range is up to the 350 beats per minute. In the PSVT, usually it is 150 to 250 beats per minute. And you can see here the sawtooth appearance, what I was telling, when you look at the ECG, it looks like a sawtooth appearance. One more example, last example of arrhythmia which we'll take. Here you will find the irregular rhythm. Heart rate, if you measure it by another method, 100 beats per minute. Again, that is a ventricular rate we have seen. If you look at the P waves, there are no P waves here, no P waves. Some abnormal waves are there. So again, same like before, we can see there is atrial depolarization waves are there, but not P waves. And these are very small, just like a vibrations going on, which are known as fibrillation waves. So when you find these fibrillation waves and you count these fibrillation waves, you will see that the atrial rate is going above 350 beats per minute. So when the atrial rate goes above 350 beats per minute, P waves are absent. There is irregular rhythm. This is a diagnosis of atrial fibrillation, not flutter. This is a fibrillation. And the etiology of atrial fibrillation is that there is a multiple reentrant pathway developed in the atrium. In atrial flutter, there is not multiple pathway. There is single reentrant pathway has developed in the atrium which is firing. But here, multiple ectopic foci or reentrant pathway has developed in the atrium. A simple way always I am telling to remember the etiology of atrial fibrillation is twinkle, twinkle, little star going on in the atrium. Multiple stars are twinkling inside the atrium, multiple reentrant pathway has developed. So this is, in short, we have seen about how to read the rhythm and how to utilize our knowledge of reading of rhythm in some of the arrhythmias. And definitely I have not covered all the arrhythmias. I have just given an example of some of the sinus, some of the non-sinus arrhythmias. When in future, later on the time permits, we'll go for a separate lecture for higher in terms of arrhythmias and all those things. Coming to the second step of analyzing the ECG. First step I told you is analyzing the rhythm, then analyzing the axis, and analyzing the individual waves and segments. Individual waves and segments already we have analyzed while we are analyzing these things. Now we'll go for a little trickier thing, which is, again, students are feeling difficulty, is interpretation of axis. First of all, before interpretation, what is axis? What does the axis means? And before going to axis, there is one more term used here is vector. And vector is nothing but this arrow, what you are showing here in the diagram is known as vector. And the vector is a diagrammatic way to show the strength and the direction of the impulse in the heart. So if I'm drawing the arrow in the downwards here, it's showing you that the impulse is going in this direction. And the size of the arrow will show you what is the strength of the impulse. The smaller the arrow, the smaller the strength. If the larger the arrow, larger is the strength. And to understand this, you have to check the football field, what we are doing at the football game. You know that in football, there are many players are there, and they pass the ball to each other. So the ball may go in this direction, in this direction, in this direction. They are playing, all players are playing in different direction. But this team A, if I ask you what is their mean direction of the play, then you will say the mean direction of the play of the team A is from right to left. And this is what we mean to say by the mean electrical axis of the heart? If you see each myocardium, the impulses are going in different directions, but if you combine all of them, the mean direction of the flow of the current is from the right atrium to the apex of the heart. And this is known as mean electrical axis of the heart. And mean electrical axis of the heart, we measure by looking at the vector, the mean vector, how it travels under each electrodes. And for that, what we are doing, we are drawing a 360-degree circle around the heart. And when we look at this vector from different leads, we see that at what angle this vector is moving, we have to determine. And what we are doing, we are drawing a 360-degree circle, and this circle we are dividing by 6 lines. You can see we are dividing this circle by 6 lines. So this 360-degree will be converted into divided by 30, 30, 30 degrees. And if you just look at carefully, all the degrees which is mentioned in the upper part of the circle is in negative values. And all the values which I have mentioned here below is positive. Why it is so, and from where this 6 lines has comes, which is known as hexaaxial system. Let me tell you in this 2 minutes, this hexaaxial system, from where it came. This is the normal direction of the impulse. This is a range -30 to +110. But from where this 6 lines has come, you know that there is a triangle in the ECG, Inthovian's triangle, which is formed by lead 1, lead 2, and lead 3, these 3 standard leads. Let's break this triangle. And all of you, I think those who attended me, they knows why I'm breaking the triangle, isn't it? Let's break the triangle, so that this triangle will meet in the center. So now we got the 3 axes, but 3 more axes are required, which is, now these are standard limb leads. Let's take 3 augmented limb leads, AVR, AVL, AVF, then combine them, lead 1, 2, 3, AVL, AVR, AVF. Now we got 6 lines, you see. So we got the hexaaxial system in the circle now here. And why I put all the negative values above and the positive values before? Because whenever the left foot, which we are using for the ECG, you know, it's always positive. We are teaching that left foot is always positive and the right arm is always negative. So when you see the polarity of the axis, all the connections to the foot is positive. That's why the angulations which is coming down is positive and angulation which is coming above is negative. So the normal range of axis is -30 to +110. This is the normal axis. This is a range, normal. -30 to +110. Anything here, -30 to -90. If axis is going here, then this is known as left axis deviation, LAD. If the axis moves between 110 to 180 here, this is known as right axis deviation. And if axis is somewhere here between 180 to -90, this is known as extended right axis deviation, extended right axis deviation. So these 4 probabilities are there, whether it's a normal -30 to 110, left axis deviation, right axis deviation, or extended right axis deviation. And please keep in mind that we are measuring a QRS axis. We can measure the axis of each leads, P wave or the T wave, but when we don't mention anything that which axis we are measuring, it is always applies to the QRS axis. And commonly in the practice, QRS axis is only measured. Now let's see that how to measure this axis, mean electrical current flow from the heart, in which direction it is from the ECG. And there are 2 methods. One is most accurate method using the graph paper. Whichever method, another one is a crude method. I will tell you both. For both methods, you have to select lead 1 and lead AVF. 2 leads you have to select which is perpendicular to each other. These 2 leads we are selecting because they are perpendicular to each other and they are looking at each other from the 90 degree, from different angles. So they will give you a better idea about which direction current flows. So we can select now lead 1 and lead AVF. What next? Take a graph paper So we have a lead 1 here and lead AVF. Now draw a lead 1 on the graph paper, draw a lead AVF on the graph paper. Now, as I told you before, everything below is positive values, everything above is negative values for AVF. This is lead 1. Lead 1, this is right arm and the left arm, and you know that the right arm is always negative. So from the center point here onwards, all the values on the right side are negative and all the values on the left side is positive. So on AVF, we have values positive here, and on lead 1, the positive values are here. Now let's count from this lead. What you have to do, you have to count the positive, first mark the isoelectric line here. You don't have to look at the P wave, you don't have to look at the T wave, just look at the QRS complex. And we have to count the positive component. Positive component means anything that moves above this line is positive, anything that moves below this line is negative. You have to count both. How many positive component, how many negative component. How many means you have to count how many small squares above the line is positive, how many small squares below the line is negative. So let's count it together. It is both. So it is 10 small squares positive here and 2 small squares are negative here. So I can say 10 minus 2 equals to positive 8. Similarly, we will do that for AVF. But now first thing is lead 1. We measured 8 and we have marked 8 here. How we have marked here? This is a 0 point. You have to count from here the 8 small squares. These are 5 small squares and then 3 more. This is 8 small square I have marked here on the lead 1. Because it was positive, I have marked here. If it comes negative, I will mark somewhere here. Let's count for AVF. Similarly, positive component, negative component. We have 15 positive component here, taller R wave, 15, and the 3 negative components. So again, the result is positive, that is 12. And as I told you in the AVF, now the positive component are below. I had to count here the 12 small square and mark it. So this is the marking I have done for 12 small squares positive on the AVF. Now draw a perpendicular line from here. Draw a perpendicular line from here. From both, you draw a perpendicular line and then just join it from the center where these 2 lines meet. And this is nothing but the axis. We just measure the angle here, and this is the axis of the QRS you have measured, which seems to be normal, is around minus 59 degree, around 60 degree, because we have a range minus 30 to plus 110. But this is a theoretical method. Hardly anyone uses this method in the clinical side, on the bedside of the patient, because it consumes too much of time. Although it gives us the accurate axis of the ECG, but this takes too much of time. Apart from too much of time, again, the same problem comes, is why we have selected the medicine, isn't it? And you are looking at me with anger. Again, this man is today want maths only, nothing else. That too on the weekend. No, don't worry, we will escape. We will find some other way. So this is, let's see some crude method. Lead, again, the two leads you should not forget. Lead 1, lead AVF. Always look at it. For example, if the lead 1, what you do here by mistake, it's 2 is written, but please correct, I apologize you for writing this wrong thing here. It's AVF, second lead is AVF here. Lead 1, lead AVF. Always put lead 1 above and lead AVF below. In your imagination, whenever you see the ECG, put lead 1 above and lead AVF below. Most of the component you can see in the lead 1 is positive. Lead AVF is also here, most of the component are positive. So you have to draw, if it is positive, draw upward arrow. Lead 1 positive, lead AVF is positive. This is normal QRS axis. Second possibility is that lead 1 is positive, but lead AVF is negative. You see this is upward arrow, this is downward arrow. Now you can see that both these arrows, they are going away from each other. And in English, we are telling they are leaving each other. They are leaving each other, which starts with L. Leaving starts with L. So this is left axis deviation. The third possibility is that the lead AVN1 is negative and lead AVF is positive. So both of these arrows, they are reaching each other, they are coming to each other. That's why we are labeling it as right axis deviation. And the last possibility is that let me connect the wire to the, I'm sorry for that, I was connecting the charger. One is negative and the AVF is negative, and both arrows, they are going downwards, and this is known as extended right axis deviation. So it becomes too easy for us, but only one thing you have to remember, you have to always keep the lead 1 above and the AVF below. Both are positive, normal. Lead 1 positive, lead AVF negative. This is left axis deviation. They are coming to each other. That means lead 1 positive, lead AVF is, lead 1 negative, lead AVF is positive. This is right axis deviation. Another way of looking at it is through the thumbs. Use your both of the thumbs. Keep the lead 1 above and AVF below. If both are positive, this is normal. If one is positive and AVF is negative, they are leaving each other. This is left axis deviation. If one is negative and AVF is positive, this is right axis deviation. Like this, you have to go on. And both are negative. This is indeterminate. This is another way of looking at this lead 1, and instead of drawing an arrows, you can use your thumb. So this is the simplest method of doing the access. So practically, you can look at this ECG, 12 lead ECG. We can determine the axis simply. This is lead 1, and you can say this is positive. You can look at the lead AVF. This is also positive. So both are positive. That means this is the normal QRS axis. So it becomes very easy. You see, within seconds, you can say, you can comment about the axis. So this is all about the analyzing the ECG in 3 steps. The first thing is rhythm analysis. Second is analyzing the QRS axis and analyzing the individual waves and the segments. But whatever we have covered, it was just in short because of the time and because of the group. This is a very wide group. Some are from the very basic level, some might be from the higher level. So considering that, I have just covered some simple basics about the ECG. But if further, like for a higher group of students, it might be just a revision, and nothing new for them. But we may arrange a special session later on, our ECG course, in which we may split the groups. And for higher group of students, we can go a little higher in ECG reading. So thank you very much for listening to me very patiently. Any question, anything? I will just hand it over to Arshi.
Thank you, Dr. Sharique, for the splendid webinar. Those who would like to speak can raise their hands and ask their questions, and others can write their questions in the chat box, and we will answer them.
So I hope no questions are there.
If nobody has questions, we can end the meeting now.
Sure. Thank you very much for listening. Inshallah, hope to see you soon in a good health. Thank you very much.
Thank you, Doctor.